I am here with Dr. Jeffrey Durmer. He is a neurologist, a neuroscientist, and he has a PhD and an MD from UPenn. He's worked with U.S. Olympic teams, the NFL, and is always on the cutting edge of sleep. So today we're going to talk about all the things about sleep, wearables, tracking, and data and information. This is the 80/20 podcast where we try to find the easiest way to get the biggest impact possible. Thanks for coming on. I really appreciate it.
Glad to be here. Thanks for coming.
Cool. So the first thing I wanted to talk about is sleep stages. How accurate are the sleep stages on all these consumer wearables that we have?
Yeah. Okay. So sleep stages. First, let's start. What is sleep stages, right? I mean, that's the first definition. The idea of sleep stages actually came out of a technology called polysomnography. And it was really looking at the EEG, the brainwave activity associated with what happens during different phases of sleep. And so things like REM sleep, which was really first identified back in the 1940s and 1930s by Azarensky and his colleagues at University of Chicago, was the first time we actually knew what a sleep stage was. We didn't know that you went through cycles, in fact. After that, a lot of people started looking at how are these sleep stages similar and dissimilar. And so polysomnography, which is the way we test, and it was discovered and utilized at Stanford back in the 70s for the first time, is the way we quantify these different cycles that you go through during the night. So the idea of sleep stages is very much something that we created based on what we see as a signature in the brainwave activity, eye movement activity, muscle activity, as well as other things like breathing and oxygenation. So stages are really something that you need to see a 30-second epoch of time to create a stage. And one of the things that probably most people don't recognize is that in a sleep stage, in a 30-second epoch, half of it is enough to call the whole stage REM sleep. Half of it is enough to call it N1, non-REM sleep stage 1. So there's missing data, in other words. You could have like 2/3 of the stage of that 30 seconds actually REM sleep, and the other is deep sleep. So that would be very confusing because we've lost the deep sleep. That epoch is now all REM sleep. So when you look at stages of sleep, that's kind of where it comes from. That's the actual neurophysiology behind it. So now go forward to consumer electronics. Consumer electronics that try to deduce through machine learning and algorithms what stage that 30-second epoch is, are incredibly flawed because they don't have the ability to, like the human brain, to take into consideration all these data points. They're just using an algorithm around oxygenation, movement in most cases, and in some cases looking at pulse wave and looking at cardiac activity, which is part and parcel of what changes during these cycles. So the best you can actually hope from a consumer electronic is to see potentially wake and sleep. Those are the things you're looking for. Within sleep, non-REM sleep and REM sleep are kind of hard to deduce. They're getting better for sure. So just dividing out REM and non-REM is one of the things that the consumer electronics is getting better at. But taking a look at how much deep non-REM sleep versus light non-REM sleep versus the actual REM sleep, it's kind of still not very sensitive. So I think sleep stages in particular, the kind that we've been used to for polysomnography, are not really adequately measured by consumer electronics. So a lot of people who hang their hats on, oh my God, I'm not getting enough REM sleep. Take a deep breath. You probably are getting REM sleep and probably need to use a device that actually can give you a more detailed look at your sleep itself. Because one of the things that we know from even the FDA cleared devices that you wear on the finger that do PPG analysis, those devices are basically catching data every 100 times a second. You look at other devices out there on the finger or on the wrist, they're picking up data maybe once every couple of minutes or, once every 5 minutes and sometimes. So that's one of the reasons that they're not as accurate.
Interesting. So some things to clarify, polysomnography, sometimes people write as PSG, right? Yes. And then to use that, you have to use an EEG device?
Yeah.
So what is the EEG?
EEG is electroencephalography. So electroencephalography developed in Germany back in the early 1900s was really the first time that anybody could actually see the brain is doing something while you're sleeping. For many years, and back to Greek times, sleep was thought to be a state of sort of suspended animation. And during that suspended animation, nothing happened. Well, it turns out that sleep is an incredibly active process. It actually involves multiple areas of the brain that are more active during sleep than they are during the day. And there are systems in your body that actually shut down movement, like during REM sleep, something called glycinergic disinhibition or inhibition through the spinal cord. REM sleep inhibits your musculature from moving so you don't act out dreams. In fact, we have a sleep disorder called REM behavior disorder that happens when people don't have that system in place, that's not activated properly. Polysomnography is a combination of EEG, also oxygenation, looking at pulse ox. It's a combination of that with respiratory inductance plasmography, or RIP bands that look at chest and abdominal movement. We also use actigraphy to look at body position. Also, we use eye movements, so EOG, and that electrooculogram actually is something that tells us about the rapid eye movements of sleep, slow rolling eye movements, upward and downward movements. And those are all used in combination with other things like movement. So we put leads on the legs, EMG, to look at electromyography of the legs to look at twitching, which occurs in different stages of sleep, but also can detect sleep problems like periodic limb movements, which go along with things like restless leg syndrome.
And these are all clinical technologies.
You got it.
And then on the consumer side, they're called PPG, which is using light to measure.
It's one of the technologies. So one of the technologies that the first technology, sort of the Fitbit, original Fitbit technology that we'll talk about, was accelerometry or actigraphy. So that's just movement detection. And it can do it in 2 dimensions or 3 dimensions. So we could actually see the body moving at night. You can say that, actigraphy is a correlate to different stages of sleep. So during REM, as I mentioned, your body's inhibited. So there's no movement during REM, except for twitches. There are twitches during REM. So if you build an algorithm that can see quiescence and then twitches, that can probably successfully predict that period of time as having REM in it. The problem is that REM is discontinuous. Those 30-second epochs, as I mentioned before, they're not all REM. So the device itself can be fooled. So actigraphy was the first concept behind these wearables. And that's why you wore it on your hip and just moving, right? So those were the first wearables. After that, the idea of using the PPG wave, which is looking at the pulse plasmography wave, that actually is something we use for pulse oximetry in medicine. Turns out that goes back many, many years. Pulse oximetry is very useful, but that idea of transmitting light through the skin to look at oxygen and then also the pulse wave, now we can use that pulse wave as another predictor of cardiac and respiratory function. It turns out there are algorithms, something called the cardiopulmonary coupling algorithm that was developed at Harvard and has now subsequently been used in many different kinds of experiments and research, is also a tool that we use in sleep medicine. And it's FDA cleared to diagnose sleep apnea because you can see cardiopulmonary function through this algorithm because it's detecting autonomic fluctuations, parasympathetic, sympathetic fluctuations. So PPG was sort of an advance for a lot of the devices out there using PPG and pulse oximetry, because now you've got respiratory cardiac function, you've got oxygenation, and also the actigraphy, the movement. So those can be combined and much more successfully predict not just sleep stages, but also issues like sleep apnea, restless leg syndrome, periodic limb movements at night, and just give you a better picture of your sleep architecture.
Yeah, it's interesting. A lot of people, I think, focus on the sleep stages because of these technologies.
Yeah.
But I'm assuming the more important piece to focus on is maybe insomnia, RLS, and these other factors. I know that you've worked with a lot of people around sleep. Like, what are the most common issues that you found in sleep, and what are kind of the negative effects that can happen if you do have any of these?
Sure. Yeah. I mean, I don't think people realize how common sleep disorders are. That's one of the things that I find really interesting when I have conversations with groups that are very much about athletics and physical activity. They're like, well, we're healthy. We don't have medical disorders. Like, well, you can still have sleep apnea. You can still have restless leg syndrome and be healthy. It's just over the course of time, if those go untreated, your health will deteriorate. So that's one of the things about sleep problems, and even simple things like insomnia, which is a symptom, but it's also a disorder. So it's a lot of people have insomnia who have RLS as the actual disorder, or apnea. They can actually, over the course of time, increase the chances for cardiometabolic disease. So a lot of studies have shown longitudinally that people with untreated sleep disorders, that they have a much higher risk. Their odds ratios are like 3-fold higher than the rest of the population for metabolic disease, cardiac dysfunction, arrhythmias. So arrhythmias like AFib, very well understood in terms of the relationship there. Metabolic syndrome, certainly also the risk for stroke and heart attack go up in those populations too. And again, it's not happening overnight, it's across time. So if you're healthy in your 20s, but you have sleep apnea in your family, because it's got a genetic predisposition, you want to know that, so that as you get older, you're not going to end up in one of those disease categories that potentially is accelerated by these sleep disorders. So just to give you some epidemiology, the actual sleep apnea population in the country is probably around 10% of Americans. And that's a much higher number than most people realize. And sleep apnea itself runs the gamut. It's a spectrum. We all have a little bit of sleep disordered breathing because of our airway. There's a kink in the airway just because we walk on 2 legs. We're not quadrupeds, we're bipeds. The other thing too is the soft tissue around the upper airway is flexible and movable because we have a voice box that gives us the ability to speak. That combination makes it possible to suck that airway closed. And we all have a little bit of that at night. So snoring is on one end. It's sort of like not great to have snoring because it wakes up other people, but it could also be a sign of the airway sucking itself closed over and over again. And so snoring to something moves on to a different issue, which is mild sleep disordered breathing or sleep apnea, which could in fact increase the chances of problems down the line. But then when you get into the moderate and severe forms of sleep apnea, which means it's happening so many times during the night, 15 times an hour, 20 times an hour, 30 times an hour, that's where we see the risks, even in the daytime, of just accidents go way up. So our airline pilots or truck drivers, they get screened for these things because it can cause a problem that next day associated with alertness. So restless leg syndrome is another one. People may have heard of restless leg syndrome, but it's much more common than we think. In certain populations, it's as high as 12 to 13% of the population, Northern Europeans in particular, but in others we see it as well. So, this is something that if we were to understand that 10, 15% of the population in terms of insomnia, 20, 25% of the population is suffering with these issues, and actually they could be addressed, that's really where the sort of the rubber hits the road. If you look at cancer rates, it's much lower than these other issues that we're talking about in terms of sleep disorders, yet we know about them. So this is sort of the disconnect in our culture. We don't look at sleep as potentially important compared to cancer, which probably sleep disorders predispose you to cancers too, and we have data on that as well.
Interesting. So if the rates are so high, what are some ways that someone could easily be able to test to see if they have it or not? Like, is there a survey I could do, a wearable I could use? Is there any tool, a strategy where I can figure that out easily?
Yeah. So unfortunately, medicine in our country is a little fragmented. So one of the problems, even as an academic, I would work with patients from all over the country who would come to see us at our institution. And it was really evident that they didn't have the healthcare that they needed for their sleep anywhere in their environment. They'd have to travel, hundreds of miles to go to see somebody who knew something. That's a problem. And then also after we diagnosed the issue or gave them a therapy or therapeutic idea, they had to follow up on their own on all of this stuff. So they didn't have the support that was necessary. So that's a problem with our infrastructure, our healthcare infrastructure. We're not teaching our doctors enough about sleep and sleep disorders. I know that because I've taught them for years, and we basically give 2.5 hours, 3 hours of education about sleep. It's months of education about heart disease. So big inequity there. So doctors walk out of medical school really unequipped, ill-equipped to manage these things. So that's actually one of the problems that we sought to actually solve with building companies that go directly to people like Absolute Rest, which we go directly to people who don't have the ability to get that kind of healthcare or who want to improve their performance based on their sleep. And they come to us and we do a full battery of these kinds of assessments, from psychological to behavioral, environmental in terms of where you sleep, but also the physiologic. And then we do actual data collection to show where are the issues that we need to address. And then we develop programs to address those issues. It's just not something you can get in healthcare, unfortunately.
Yeah. What if someone can't afford something like absolute rest?
Yeah.
What are maybe a few strategies that they could try to implement in their life, or something they could change about their environment, behavior, pathology, physiology that could hopefully improve their sleep?
Well, actually, really quickly about absolute rest, we are making a product that's going to be much more affordable, and it's going to be coming out in the summer. So keep an eye out for that, because that one will be not just for elite athletes, it's going to be for everybody, and it's going to be very much technology enabled.
Are you allowed to say what it's called?
It's called the Lens Program. So it's going to be the Absolute Rest Lens Program. We're going to be launching it in the summer, and it's basically going to make the opportunity available to almost every American. It's not, we don't want it to be tens of thousands of dollars to get this care. We want it to be hundreds, if that. So that's what we're looking forward to.
So like, for example, my parents are not very technology intelligent. I could buy this for them and hopefully figure out if there's any sleep. Okay.
Absolutely. In fact, what we do in our program is we develop an advocacy program. So within the program, when you join it, you have somebody internally who's going to be there to support you through it. So that way we understand that this is not something you're used to doing. It's not something you've ever seen before. So we have programming to do that. And technology is really, even my parents know how to use technology, right? Even in their 70s, they're able to do their iPhone. Yeah. So if you're able to do that, download an app, you've got what you need from the Absolute Rest Program to help you tailor something that will be more specific to you. So that's one thing. But if you don't have anything right now, and before the summer hits, some of the things you can do and really look around your environment, and also look at your own behaviors around sleep. So one of the things that we often have is people come in with like a Whoop band or an Oura Ring or an Apple Watch, and they say, hey, it's telling me these things. Take a look at just the sleep environment where you are. Do you have a television in your bedroom? Do you have a radio or something that you utilize every night? Are you on social media every night? I know you are. We've talked about this. But that idea of being on social media or being engaged in something that is actually activating is not what we want to do in the bed or the bedroom, not just for sleep, but just because the bed in the bedroom is something that we build a relationship with. It's a stimulus, and the stimulus actually is go to sleep. That's what the bedroom should be telling you when you go to your bedroom. If you go to your bedroom and you feel anxious, or you feel, I need to check my email, or I'm waiting for this call, that's not the feeling you want in the space that I call your sleep sanctuary, not your bedroom. It's actually a place that should be very devoid of the day. So dark, cool, under 68 degrees if possible. Also keeping it quiet so that you actually reduce the novelty that could actually wake you up in the middle of the night. These are all essential elements that you can do in your own environment. You don't need us to do that. We do that because people often recognize these issues. But that's where it kind of starts. And I think in our handheld culture right now, that's a major issue. And, there's been a lot talked about in terms of anxiety and depression and kids that are going through a lot of these issues with using social media or being bullied on social media. So the more we can actually remove all of that from the sleep environment, it kind of opens up a new window of sort of what's important about sleep. Sleep is not just something that you do at the end of the day. It's actually the beginning of the next day. So you look at sleep that way. Change your cognition about sleep. Sleep is not the end of the day. It's tomorrow. Then you start to prepare for it in a way that you prepare for the next day when you wake up in the day.
Cool. I want to dive deeper into the things that you mentioned around keeping it dark. So would a good example be blackout curtains and like a sleep mask?
Yeah. So I live here in Denver, Colorado. Anybody who lives in a place that has a lot of sunlight, we have 300 days a year. We need to have the ability to block out the sun at certain times of the day, especially at times of the year. If you live in northern climes where it's light almost 18 hours a day, you need to have some way to block light out in the evenings, because light itself is the major stimulus for wake. And it activates not only the cortisol response, it not only activates parts of the hypothalamus that create things like hypocretin and other neurochemicals that activate for wakefulness. Light also shuts off the sleep centers of the brain. There's an active area called the ventrolateral preoptic area, VLPO, that it is one of the trigger areas to start sleep. And light in the morning hits your eyes, goes back to the suprachiasmatic nucleus, and activates wake and deactivates sleep. So it does two things. That's why it's so important not to have light later at night, not just because it wakes you up, because it's shutting off your sleep system actively. Sort of the same thing with caffeine. Caffeine is something that inactivates adenosine. It's an adenosine antagonist. Adenosine is your neurochemical trigger for sleep. So why we use these in the morning makes lots of sense. Get lots of sunlight, have a cup of coffee or two, but keep it in the morning, because those things that you're doing then are accentuating for the day. If you do those things later in the day, you're wiping out your opportunity. I call it the train. You're trying to catch a train. The sleep train comes only every hour or every couple of hours. If you miss the train because you were sleepy but you stayed awake because of these activities, you're not going to have the opportunity to get into sleep like you should.
Blue light blockers.
Oh, blue light. Yeah, sure.
So there's obviously the clear ones that people wear during the day. I don't know if those do anything, but the night ones with the red tint, I know you dim the lights. Obviously, the amount of light that you're getting. Does the color of the light matter, or is this all just the trend?
There's a lot of information from circadian neurobiology that parts of the retina that actually absorb light that activates these subcortical non-visual system areas that are associated with wake promotion or reducing sleep activity. They are activated more so, they're retinal ganglion cells that are activated by blue and green light. So blue, green, sky, grass, they activate for wakefulness more so than just visual activity. So if you think about it, if you reduce blue and green wavelength activity in the 400 to 500 nanometer lux region, that will actually help to reduce the activity of those retinal ganglion cells, reduce the pathway to the hypothalamus associated with this. That's the theory. In practice, people put on blue blocking glasses, but still do things that are novel, like get on their computers. So you're kind of at odds there. And the idea that just by blocking the blue light, I'll be okay, it's a little bit of a false premise, because the light, yes, if it's just light you're trying to block, they work. Actually, the experiments have demonstrated that. But if you're doing it on your iPhone or you're doing it on your computer, it's not likely going to have that much of an effect, because the major effect is the novelty, is what you're doing, the activity and the social activity.
So the novelty is sometimes more powerful than the light itself.
The novelty is the most powerful thing that drives us. Yeah, think about it. That's why people go online.
Just scrolling away. And then the next thing you talked about was cool temperatures in your bedroom. I know you can cool the area. You can also get an active cooling bed cover.
Yeah.
What are your thoughts on those?
Yeah, so actually I've used those with our Olympic teams, especially the big-bodied weightlifters, because they sleep hot, and a lot of us do who are active. The idea of cooling the room was sort of a good idea to start with. So if you can get your temperature down in this around 68, that's great. The main issue, though, is that people will put covers on and they'll get hot. And one of the things that happens during parts of sleep, especially REM sleep, is we become poikilothermic. And poikilothermic is basically reptile. We become no longer warm-blooded. So we take on the temperature of the room during those stages. And that's why some people wake up sweating in the middle of the night when they're under blankets, even though the exterior room is cool, because they're under blankets and they've taken on the temperature of like 100 degrees. Versus when you're freezing cold, because the same thing can happen if your feet are sticking out. So the idea of cooling the bed is likely to be a better concept. And the idea of having it thermostatically responsive to your body is also a really good idea. And so I did this with the Olympic team in 2021 actually, for Tokyo. And we put these mattress toppers on the device, on the tops of the beds. Didn't use the ones that are out there nowadays. It was a device called the Chili Pad, which you can still get them. They're actually really cool. And I like the company because they make them, they're somewhat affordable compared to others. And they just go on top of your mattress, and they have microfiltration system of water that pumps through this topper, and it can actually be set to a temperature. So I did this with a bunch of the weightlifters, and the bigger ones, they was sort of like, do not ever take this away from me. They take it on vacation with them. It's just a wonderful advance. So I really do support that for people who sleep very hot, who can't get their room to actually get them more comfortable. I think it's very helpful.
So like as a marathon runner versus a weightlifter with a lot of muscle, is someone with more muscle more likely to run hot when they're sleeping?
Well, metabolically, yes. I mean, you're actually going to be throwing off a lot of, when you're cleaving ATP to make energy, you're making heat. So part of the issue is that is going to potentially relate to your sleep stages too, and what happens during those changes that you go through, those cycles. But it's not always a hard and fast rule. I mean, there are many younger marathon type people that also sleep hot. So, it oftentimes is associated with your genetics and your body type. Yeah.
Okay. And another tip I've heard you say, and other people say as well, is warm shower or sauna before bed. That helps your body cool. But heating it up, how does that help your body cool? One, and then if we're getting in a bed that's cold, why not heat the bed too? Won't that help our body cool?
Well, no. So
how does that work?
So how's it work? So what we're trying to do is get you to radially cool. So the idea is that let's go back to the laboratory. So in a sleep laboratory where we're doing polysomnography, in research studies, we'll actually look at core body temperature. And we do this through a rectal probe, actually. So it's not something we like to do at home. But the rectal probe actually gives us a core temperature that we know when it goes down, there's a trigger in the brain for sleep. So temperature change, core temperature change, actually is associated as another trigger for sleep onset. So how do we get our core temperatures down? It's not peripheral. Like, if you got Raynaud syndrome, don't freeze yourself because it won't help. But the idea of getting into a warm shower is you're vascularly dilating your periphery. So basically blood is rushing out to the limbs and outside of the core, and it allows you to get the blood moving away from the center. Now, if you turn that off and step into a cool room, you'll get vasoconstriction. Yes, that's one thing. But also the blood that's been pulled out into the periphery will now cool radially. So the idea is to dry off in a cool space, let yourself cool down from the warm shower. It's not hot shower, just a warm shower. And then you're going to end up cooling your body. The idea is to radially cool. Sauna might be a little too hot, actually. So we don't want to activate too much. It's the thing about a sauna at night. If you use a hot sauna or even a hot tub, those tend to be a little bit more sympathetic surging because they cause a little bit of a response. Sort of like if you jumped into an ice bath. That's another thing I've heard people do at night. They jump into an ice bath to cool their body. I'm like, you just activated your sympathetic nervous system because it's a fight or flight response. That's probably not, we're working at odds, let's say. So I really like the idea of people doing their ice baths earlier in the day, especially with workouts, so that they can actually get the anti-inflammatory benefits. But then in the evening, do the warmer routine to cool your body, and that tends to help. The issue about the bed, warming the bed, is not warming you. Actually, it's not causing the peripheral vascular dilatation and getting rid of heat. It's actually retaining heat.
So by cooling, I guess the concept of the warm shower is like I heat up my body, blood flows to the skin, I step into a cool room, and now the blood cools down, thus lowering my core body temperature. And then inside the bed, if the bed is cool, does that also help? Because it's not too cold, like ice bath cold.
It's maintaining it. Okay. It's maintaining the cool. So now when you're in bed, if you're going into sleep, throughout the night, you're going to have those changes in going to REM and non-REM. And as you cycle through, keeping your body cooled, it's like if it warms up because you're under the blanket, the mattress topper can actually sense that and deliver a little cooler water to the spot where you are. And that will actually help to keep you cool, theoretically. I mean, it's just not clinically proven, but that's the idea.
And I don't know if you've heard of those palm cooling devices.
Yeah, the Bear Claw.
I haven't heard of Bear Claw. There's Coolmint, there's like Ava cooling bars or something. Yeah. But those also it's called glabrous skin, I think, that's on your palm. And they supposedly help reduce your core body temperature in an exercise setting. Could you use that to help reduce your core body temperature before sleep?
I don't think theoretically. I mean, so this is actually, the Bear Claw was actually developed at Stanford. It's actually the original device. And I think the first time I saw it used, it was in demonstrating the quick recovery of muscle function, so that you could put your arm into this. And the idea was that it created a bit of a vacuum in the space so that it maintained the dilatation of the blood vessels. So as they delivered a cooling sensation to that area, it didn't cause vasoconstriction. And that when it was radially cooling and pulling the heat away. And they call it the Bear Claw because that's how bears get rid of their heat. So the idea was that would actually improve muscle function because you're removing this part of the metabolic process from the body, which is actually inhibiting you from muscular activity. And then they could demonstrate that somebody could do like 20 pull-ups till exhaustion, put their hand in the Bear Claw, get back up and do another 20, versus somebody who would just slowly decline over the course of minutes. Potentially, that could have some effect. Again, I don't know how much of the total core temperature that we're reducing here, but it's potentially possible, yeah. Be interested to see if anybody out there has done that.
Yeah, okay. might not be worth the time. It might be something interesting to try, but not something to do on a daily basis. And then the last piece was noise. What the best solutions? What would be the best solutions there? Like earplugs, white noise machines. Like what can people do that?
Yeah, noise is interesting because if you think about the auditory system, just the input to the auditory cortex, there is a baseline activity in your inner ear. In other words, the hair cells that detect sound, they have a baseline firing rate. That's that background kind of ringing you hear when it's quiet. And when it gets really loud, like what we call tinnitus, that's more of a cortical phenomenon replacing the lack of hearing. So the idea that your auditory system is always active. And if you go into a sleeping stage or into a sleeping environment and you have novel background sounds, car noises, dogs barking, children screaming in another room, that's going to alert you. Again, novelty. It's going to wake you up. So the idea is maybe one of the things you can do is increase the basal firing rate of your hair cells. And you can do that by activating the background sound. And so the idea of white noise, pink noise, brown noise, choose your color, whatever makes you relax, that actually has been shown to increase the background activity of the hair cells, and it drowns out the other sounds that are novel. So the idea of a white noise background can be very effective with sleep. Even more so than putting something in your ears, which could be uncomfortable for some people, and also moving may fall out. I know some folks have sleep masks that actually go around their ears as well. So you can do the mask with the eyes and the ears together just to reduce that input. But if you don't like things on your face, if you don't like things on you, just having a background sound, even the whir of a ceiling fan, can improve your sleeping environment enough because it's increasing that background activity of the hair cells in your auditory system.
So it's like these novel sounds are kind of this sharp up and down, and the goal is how do we increase that baseline so those sharp up and downs essentially are
It's the picture that we actually draw for people. Like, this is what's happening, and if we do this, you never have that issue. Yeah. So it's about finding the right color sound that you like, that you enjoy. And I think there have been enough studies on every color to say that they all work.
I want to ask a question around wearables again, but this one's around that. I know you've talked about there's 3 things that you can trust from a wearable. What are those like 3 main variables that we can trust, and then everything else maybe we don't look at as intensely?
Well, again, wearables are about movement. That's why they are wearables. So trust what the movement activity, the actigraphy is telling you. And that's why people use it for steps and a number of activities. Now, I know it's flawed for people who do CrossFit and do pull-ups and it doesn't register a thing. But the idea that actigraphy is really the one thing that it does well, you can rely on that. So when you look at sleep, the things that I would suggest that you potentially pay attention to are more of the behavioral aspects. And those are things that you can impact duration of sleep and timing of sleep. The other neuroscientific concept is sleep quality. I don't think you should look at your wearable as a device that's going to tell you a lot about sleep quality. We only have one device actually FDA cleared to do that. And it's something we use in Absolute Rest. It actually looks at the autonomic nervous system, and it gives us a real objective quality metric. None of these other devices can do that. So focus on the amount of sleep you're getting, the timing of your sleep, and the regularity of your sleep. Because it turns out regularity is one of the things that you can impact yourself just by making sleep a priority and preparing your sleep time before you get to sleep. The idea, again, of falling asleep at the end of the day is not the idea. Prepare for the next day with your sleep. So use it for duration, use it for timing, and also look at it from like the social jet lag component. Like somebody like you who travels around the country, you actually experience jet lag to some degree. Most of us don't travel that much, but we do sometimes, I don't know, stay up on the weekend, go to concerts at Red Rocks, that sort of stuff. And that throws off your entire circadian rhythm. So as much as you can, try to keep it within a couple of hours of your typical work week, if you will, schedule, because the idea of having that regularity creates the systematic sort of preparedness to go to sleep. So you'll improve your chances of sleeping on a night-to-night basis.
Well, I know one thing around duration. So one of my trackers, maybe some of them, will say, all right, this is your sleep need. This is how much sleep you need. And I know I listened to some stuff, and you mentioned how you were an elite rower. You have kids who are elite swimmers. How does the exercise that you do in the day actually impact sleep need? And can that, one, be measured by a wearable? And 2, how do I figure out what my sleep need is the next day based on exercise type, exercise duration?
Good question. Actually, so one of the things that you can go like to the CDC website or the National Sleep Foundation website, you can find a nice infographic about the different sleep needs and the windows of sleep duration by age, because it changes dramatically from childhood all the way through adulthood. So the average for an adult is 7 to 9 hours. That's what we know from all the epidemiologic data. We know that there are some people that sleep a little less, so 6 is sort of the bottom line of the population curve, and 9 is the top of the line. So if you're anywhere between 6 and 9, you're in the window. 6 is probably not enough, but 7 to 9 hours is probably right where you should be. That's sort of what a lot of our wearables tell us. They tell us sort of what we know from the website. And that's good. I think as a population, you fall into that 7 to 9 hours, that's great. The issue, though, becomes if I'm an athlete and I'm using up what we call metabolic equivalents on a daily basis, far more than non-active regular people, or NARPs as we call them, that is another reason that you're going to need more sleep. So one of the things we talked about earlier is that caffeine is an adenosine antagonist and actually is one of the triggers for sleep, so you don't want to have it late in the day. Well, adenosine is also a part of your ATP. It's actually the A in ATP, adenosine triphosphate. When you use up adenosine triphosphate in making energy through your mitochondria, that adenosine, free adenosine, actually collects in the body and the brain, and it is the trigger to put you to sleep so that you can you basically replenish your stores of energy, put together your neurochemicals for the next day. So if you're using a lot of energy in the day as an athlete, the more you use, the more sleep you need. That's just the basic understanding. So people that put out a lot of energy, like rowers, for instance, who are rowing, hours at a time at a very high sort of anaerobic threshold level, they're using a lot more metabolic equivalents than the guy who's coaching them in the launch. So the coach needs, 7, 8 hours of sleep. The rowers probably need more like 9 hours of sleep, or even closer to 10 hours of sleep. So sleeping outside the window on the longer side is really where most athletes should be. And, I never worked with Whoop or any of these other companies, so I don't know what their algorithms are per se, but to be able to calculate metabolic equivalence would be pretty much a feat in my mind. I think you have to take that into consideration for yourself. So even a day-to-day, if you're an athlete who's doing regular workouts, they change. So if you did an anaerobic threshold workout and you know that feels really incredibly hard, and that means your sleep is going to be much more necessary for recovery. And I'll put this out there too to all the athletes. Yeah, your sleep itself is when you make growth hormone in the deepest stages of non-REM sleep. So if you're doing what we call growth hormone workouts to improve muscle hypertrophy or strength, you actually need sleep to do that. It's the first third of your night, actually, when you get that deep non-REM sleep. That's when you repair and recover and make growth hormone, and also have anti-inflammatory hormones made, cytokines and interleukins that actually heal you. It's one of the things you think about. You scrape yourself in the morning, it looks better because you healed overnight because of the anti-inflammatory effects of sleep. So you need to use your sleep as part of your program, not despite your program. Don't get up at 6 o'clock in the morning after an anaerobic threshold workout to go for a little light jog because it's a recovery day. Sleep in, get that extra sleep. That's your recovery, and then do your stuff later in the day.
Yeah, interesting. I think I love the whole hybrid athlete concept. So I love weight training to gain hypertrophy and strength. And then on the other side, I'm getting into marathon training and running and endurance. But one struggle that I have, and I think a lot of other people might have, is there's so many things I'm trying to do in the day, whether it's like working, also working out, but sometimes I sacrifice sleep. Is there something that I can tell myself to say, actually sleep needs to be prioritized and maybe you just need to skip that workout because of XYZ? Like, what can someone tell themselves from like a psychology or behavioral standpoint to prioritize?
So you may have heard of Maslow's pyramid of hierarchy, or hierarchy of needs. It's not a psychological concept that we still use these days, but the idea that there's a base of the pyramid and then things are built upon that. That's what sleep is. Sleep is actually your physiologic base of your pyramid. I mean, other than having shelter and food, these are things that you physiologically need for survival. When you look at performance, sleep actually is at the bottom of that whole thing. It's not your training. It's your sleep that sits at the bottom. On top of that is your nutrition. And then on top of that is your training. So you don't want to sacrifice your food for your training. You don't want to sacrifice your sleep for your food or your training. So the idea is to find a way to use sleep as the base of your pyramid. And it has to be incorporated into your program. So I know a lot of athletes we program for a lot of different things, but if you don't build into your program the sleep, then you're going to potentially miss it. And also create a sanctuary for that sleep so that when you walk in there, that's what it's for. The idea that people will watch an extra, hour of TV because they want to see the rest of the storyline, or they want to do a little bit more on social media, that's actually what you have to try to inhibit. You have to stop that from happening. It's not the procrastination aspect of it is actually impeding your sleep, which is going to be the base of your pyramid. So the next day, you're going to wake up feeling terrible. You won't feel that good. You want to feel good every day when you wake up. If you don't feel good most of the days, there's a problem. So think of it from that perspective.
Feel good most of the days. Okay, so here's an example. Let's say I work a 9 to 5, 9 to 6 p.m. job, but I need to do a 2-hour long run. Do I wake up early and sacrifice my sleep and run in the morning? Do I run at night before I go to bed? Or do I just skip that workout because I can't get good sleep?
You schedule it on the weekend. That's the way I work with a lot of distance athletes in particular. You do your longest stuff on the days where you have the most freedom to do it. If you go out for a long run at night and then expect to be able to go back to sleep, hats off to you. You're not going to be able to sleep. And then the sleep you get itself actually will be much more stimulated by sympathetic surge. So you'll be fragmented through the night. If you did it in the morning, that's probably the best alternative, to get up and go do that run. But understand that if you got up early, 6 o'clock is not your normal wake up time, maybe 8 o'clock is your normal wake up time. If you got up at 6 to do that 2-hour run, your sleep need is now going to increase the amount of sleep you need that night, the next night, to actually perform well the next day. So either you're going to put a nap into your day to get that extra sleep that you lost, or you're going to go to bed earlier if you can. And that really depends on you and what else you have going on in the day. For a lot of my college athletes in particular, they have 2-a-days oftentimes, and they have homework, and they have to show up to eat and all the other things. So putting a nap in the day, scheduling naps in the sort of siesta part of the day, like 1 to 3 o'clock in the afternoon for like 30, 60, 90 minutes at most, that can be a sufficient way to recapture some of that sleep issue.
So I guess time management is really important when you're trying to train for something physically while also cognitively work at your job or whatever it might be.
Which is why I say program it. That's the whole point. If you actually plan it and program it and put it on your calendar. I mean, I do meal planning, right? So you make a meal plan for the week. It's in your fridge. That's good. You want to do that. How about sleep planning for the week? Think about it just as seriously as you would your meal plan, as just as seriously as your training plan. And you'll know, when you have that hard workout or that extra long workout, you need to plan the recovery. You can't just hope it happens. It has to be planned.
Yeah. Interesting. Yeah, I guess you got to make sacrifices too sometimes, because I'm like, oh, I want to run today. I want to get work done. I want to hang out with friends. I want to do this. And then there's just too many things. And
you hang out with your friends while you're running. That's one way to do it too. Yeah.
Be efficient to combine that.
Yeah. It's sort of like walking meetings. We do those too.
Yeah. I know we've done some tests with absolute rest on me, and was one of the things that I have RLS, or like there's a potential.
Yeah, RLS is, here's the thing. RLS is a clinical diagnosis, so it's something you tell me about. So there's 4 principal issues with RLS: an urge to move or an uncomfortable sensation. It could be in the legs, or it could be in the arms, or any part of the body, but usually in the legs. That urge gets better when you're moving. So you can move and make it feel a little bit better, but it doesn't go away. It gets worse when you're at rest. And so anytime you're laying down or resting, it will actually activate in most cases. And then the last one is that it occurs in the evening more often. So there's a circadian rhythm to it. And actually RLS symptoms tend to occur worse even later at night. So periodic limb movements that actually happen with RLS can wake people at night or cause them to arouse to wakefulness and have what we call insomnia, but actually RLS or periodic limb movements is part of the problem. So in your case, you kind of told us a little bit about the urge to move, the uncomfortable sensations. It does happen at rest. It does get better, a little bit better with movement. I didn't get as much of the evening component, but maybe that is something, because I did see it in your polysomnogram. And those symptoms are actually enough to say, hey, you probably have restless leg syndrome. I also have to eliminate other things. So you don't have diabetic neuropathy, you don't have, a dermatologic condition, a musculoskeletal condition, other things that could actually mimic RLS. And then there are secondary causes of RLS, iron deficiency, pregnancy, you're not pregnant. All of those things have to be taken into consideration before you can say somebody has RLS. And then there's also some sleep testing components that are actually objective. So these are subjective metrics. The objective measurements are periodic limb movements and arousal during sleep. And so we did 2 nights of polysomnography with you. And in both cases, we saw periodic leg movements in the beginning of your night while you're trying to get to sleep, which is actually something, it's sort of a pattern we see with RLS. So it's likely you do have RLS. Again, it's genetic, it runs in family. So my next step would be to ask you about brothers, sisters, moms and dads, aunts and uncles, because it may also be associated with other things in the family. Other things that we also see associated with RLS are ADHD. A number of other conditions are also associated with RLS. So that's another thing I would take into consideration. But then also, is it really disturbing your sleep enough to do something about it? So first thing I typically do is take a look at your iron levels, because iron is a cofactor in the creation of dopamine, which is the neurochemical we think is responsible for a lot of the symptoms of RLS. And in your case, your ferritin levels were in the 90s, I think, close to 100, which is good. We'd like to see it around there, a little over 100, even better. But the rest of your indices were normal. So I wouldn't give you more iron per se at this point to help boost that. The other things I'd also suggest are avoidance strategies. So avoiding things that trigger RLS. Sleep deprivation, number one. So we'll talk more about that. Travel and things like that can actually induce it more often. Lots of exercise before bed, like high level exercise, can actually stimulate it. Caffeine can stimulate it. Benadryl and antihistamines can stimulate it. And anything that's an antidopaminergic, so compazine for like seasickness, things like that, scopolamine patches, these actually can induce RLS as well. Just like apnea, we all have a little RLS. It's a syndrome. It's not a specific disorder. And so I can induce it in anybody, even if you don't have the genetics for it, just by giving you an antidopaminergic medication. So think of it that way. It's something that we want to manage over time. Do we actually need to put something in to intervene, like a medication to increase dopamine function, or an alpha-2 delta ligand, which is like gabapentin, to help reduce arousal and improve your sleep? If we do, then we do it. But if not, it becomes like a management issue of just like avoiding the things that cause it, and then doing things that will help you avoid it. Yoga, stretching, things that you can activate even when you get the symptoms can make you more comfortable. And even using good sleep hygiene principles can make it better too.
Well, why does yoga and stretching help it? Like, how does that work?
So one of the things about yoga and stretching, and yoga itself is a meditation, in my view, it's much more than sitting there sweating in a hot yoga box. The concept is that you're actually diverging your attention away from your RLS symptoms, and you're doing something active that is deactivating that input to the central nervous system. So I think psychologically, there's a lot of benefit to it that is real. Physically, there may also be some benefit to it. And again, we don't have the data to support that from clinical studies, but physiologically, the input of information that goes into your central nervous system is gated. So you don't feel everything that's happening on your foot right now, but your spinal cord actually gates that information. That's sort of like, you ever heard the gate theory of pain? Like if you hurt yourself, like if you smack yourself, you rub it and it gets rid of the pain. It does work because it's called the gate theory of pain. By activating somatosensory into the spinal cord, you can inhibit the pain response. So what we're kind of doing with yoga is akin to the gate theory. We're activating other areas of sensory input, which will help to gate the painful or uncomfortable sensation of that urge to move.
It's almost, if I oversimplify it, it's like you're distracting your brain.
Yeah, you're distracting your spinal cord.
Okay.
And your somatosensory system that's sending that information to cortex. Because once it gets to cortex, it's hurting. You feel it. That's where you sense it. Down here, we can stop it. That's why TENS units and all these other devices work, because they stop the information from getting up to cortex. Or in a sense, they distract that information from being seen.
Interesting. The next thing I want to talk about is travel. I love to travel. I bet there's a lot of people that love to travel, but it obviously negatively impacts your sleep. I think there's multiple factors. One is time zone change. Two could be like red eyes. How bad are these things? Like, what are the potential negative impacts, and how do I mitigate them?
Yeah, I mean, things like red eyes, they happen. Sometimes you have to do things like that for other reasons. So yeah, they're not good. That's why they're cheaper. But I think the main issue is that travel itself sets you off in terms of your sleep timing more than anything else, and your wake timing. So don't just look at it as sleep timing. Look at it as, and there's some great experiments done by a colleague of mine at Penn, Hans van Dagen, who's now out in Seattle. And Hans did some work in Dave Dingis's lab early on that demonstrated that excessive wakefulness is actually one of the biggest problems in terms of performance deficits. Not just sleep deprivation. We used to always think about it as sleep debt. Oh, you didn't get enough sleep. Actually, his work showed that even over a 2-week period doing these experiments of extending wakefulness, it's the extended wakefulness that causes the deficits, not the sleep deprivation per se. So think about that when you travel. When you travel, if you're going across boundaries and you're going to be changing your timeline by hours, more than 3 hours, for let's say, you have to actually focus on how much time are you going to be awake in that total period versus also asleep. And as you know, 7 to 9 hours is sort of our recommended thought process depending on your athletics. So if you say 8 hours is the average, I should be sleeping 8 hours in the next 24 hours. I should be awake the other 16. All right, so that's my timeline. So 16, if I stay awake more than 16, I have a problem here. So think about it that way when you schedule your travel. And so the idea of a red eye is a really bad idea because, first of all, you're probably losing hours because you're moving across time zones, either one way or the other. If you're going west, you're gaining hours in a sense, so it's not as bad as going east. But if you're going west, you're gaining some hours. But did you gain hours of sleep or did you gain hours of wake? And if you've extended your wakefulness beyond that magical 16 hours, and Hans's study showed 15.35 hours, I think was the average. Beyond that, you're running into deficits. Your performance is going to suffer. So think about it from that perspective. Now, to mitigate it, how do you mitigate it? One of the things I often tell people is that if you're traveling just for like a day or two, it's not going to be your new circadian rhythm. Stay on your old rhythm as much as possible. Stay on your wake and sleep schedule where you live because you're going back to it in a couple of days. If you're going to spend a week someplace else, like you're going to go to Tokyo for the 2020 Olympics, like our weightlifters did, we actually set up a circadian camp in Honolulu so that they could readjust there first before they went to Tokyo. And they actually were sleeping on Tokyo time. So that's the idea. If you have to perform someplace and you're going there or you're going to live there for more than a week or so, you want to start actually living on that sleep and wake time where you are now before you do the travel. So as much as you can, move yourself closer to it. It doesn't have to be perfect, but get closer to it. And then when you fly, try to fly so when you land, you wake up in the morning. It's morning there because it's a lot easier to sustain wakefulness than it is to make yourself go to sleep. So if you fly in at night and you've been awake, but not awake long enough, you're going to be awake during their nighttime when you should be sleeping, and then you're going to be sleep deprived starting forward from that point forward. So a lot of my athletes, I try to have them travel so they arrive in the day, like in the morning hours, not in the afternoon or late afternoon hours. That typically helps a lot. So red eyes can be useful in that regard, but usually red eye means you're not going to sleep because it's too short. It's like California to New York red eyes. That's not enough sleep. That's 5 hours of time.
Yeah. What if it is long enough? Is the sleep on an airplane the same as the sleep in a bed?
No, but it is sleep. So you can actually improve it. The ideas we just talked about before, light, so using a mask, sound, maybe putting earbuds in for that kind of a thing. Getting a place where you can actually lay down, paying a little extra for the front of the plane, a lot extra in some cases. But even finding a more relaxing, like a reclining chair that you could sleep in. So think about those things: light, noise, temperature. Keep yourself cool. Stabilize your neck and your head, because that's another issue a lot of people have while sleeping. That your head falls over the place. There's a lot of different options out there. I don't endorse any of them, but you can try all different kinds and see which ones work for you. I would also suggest that you try to make yourself as comfortable in that if you're going to sleep, make yourself as comfortable as you would, almost as if you walked on the airplane to sleep, rather than walked on the airplane for an airplane experience. So think about it as part of your sleep, as part of your sleep time.
And what about elevation? Not only just, like right now we're in Denver, we're at about a mile, 5,000 feet high, but on the airplane as well, like I'll look at my watch and it says almost 8,000 feet elevation. Does that impact my ability to sleep and recover?
Good question. I think, so there's a lot of data about sleeping out altitude, but not for just 3 or 4 hours. So the idea that if you went into the mountains, say you went out to like Breckenridge at like 11,000 feet, or Alma, the highest point in Colorado, it's 12,000 feet. If you're going to stay there for a few days, you're going to feel oxygen deprivation. You're going to not be able to exercise very easily. You may get headaches. You want to avoid alcohol. These are the things that you should think about in the airplane too. So think about in the airplane, as much as they give you free alcohol at the front of the plane, try to avoid the alcohol. Try to avoid the caffeine. Try to avoid the things that are besides just hydration. If you're really trying to sleep, try to avoid those. I think that if you look at the altitude research, the sustained period of time at that altitude, it takes a long time for you to actually acclimate to that. That's why we use it for training too. It's not going to happen in the short time that you're on the airplane necessarily, though.
Yes. Cool. One last question. I know you talked a lot about culture, which I think is very interesting. I'm a software engineer. Well, I used to be, but now I make content, and I view content as a way to engineer humans to change culture. So my question to you is like, what is one of the biggest things that we can do to change culture today around sleep or anything?
Yeah. You've heard me talk about this culture issue a couple of times. I've been in medicine, and I've been in this culture of athletics my whole life, and medicine for the last 25 years. And what I've seen, even in the last 25 years, is a dramatic shift from helping people to manage their life and be more healthy to actually managing diseases, and much more, here's a drug to treat that. Here's a surgery to treat that. And the relationship with medicine has changed dramatically in our culture. Not to the degree of like politics, but it is at a point now where doctors are serving patients versus collaborating with patients. And it's almost like the consumerization of healthcare has really changed that relationship in a negative way. So much so that people doctor shop. I mean, shop for a car, shop around. But when you're doctor shopping, you're going to get the lowest price. What are you going to get for that? That's not the concept. The idea is to create a relationship, understanding, and also give you advice on how to stay healthy. So culturally, sleep is one of those things that has absolutely fallen by the wayside. And I mentioned this before, back in the 60s, 7-Eleven, it was a crazy idea. My grandmother thought they'll never make any money. Nobody goes out at 11 o'clock at night to buy food. And 7 o'clock, you should be sleeping. That was what my grandma's were getting up to get the worm. But that culture went from 7-Eleven to 24 hours. And that has hit like our, grocery stores, which were never open. I remember going to A&P with my grandfather in New Jersey, and, it's shut down at 7 o'clock. There's nobody there. That's definitely a culture problem, because we have basically de-emphasized the physiologic benefits, the mental health benefits, the emotional benefits of sleep itself. So I think as a culture, how do we change that? We start with our youngest members, and we teach them that sleep is important. We teach them that school start times are something that they inherently need to have changed. It's not just a nice to have. It's a changing the culture of school start times. That teenagers and middle school kids actually have a delayed sleep phase is part of their physiology, and you want to make them go to school earlier? No, that's absolutely wrong. And the data's out there. I mean, there are going to be a lot of people fighting this. Same thing with daylight savings time. It's unbelievable that our government wants to try to keep it going. We did this experiment in the 70s when Nixon was president for 2 years, and the country revolted. We have no memory for really what is happening out there. And so many of us in the sleep medicine and circadian neurobiology field are up in arms about this. We go to the government, we actually lobby them, stop the daylight savings time, get rid of it. Let's go to standard time. We should all be on standard time, because that's actually associated with where the sun is in the midday all year round. If you go to 24/7 daylight savings time here in Denver, our wake up time in the winter will be in the dark, and our sleep time will be in the dark. there will be no light in the beginning of the day, which is what we really need. We don't want to delay the rising of the sun. We want it to be timed to our sleep and wake times, because that's the ultimate arbiter of wake and sleep.
Yeah. Hopefully one day with no more daylight savings, right?
We're holding our breath on this because we think it could actually change. It's just we have to get legislature to understand that the economic potential benefits of having more extended time at night for people to go out is not physiologically a benefit to the population. This is a public health issue. It's not an economic issue.
If we can sleep better, we'll be more productive, right?
Exactly. And I will argue that all day long with Marco Rubio or anybody else who wants to have that discussion, because those are the people that are misunderstanding the importance of sleep. They may have their heart in the right place to get rid of daylight saving, to get rid of the change, but they want to go to something that is absolutely physiologically incredible, that we would do that to ourselves and to our kids. That's the group that we want to be healthy. And right now, our kids are not in the healthiest position compared to others.
Yeah, cool.
Yeah.
So Absolute Rest, that's one place where people can go and sign up and potentially buy the new lens.
Yeah.
Where else can people find you?
Find me?
Yeah.
Well, I'm out there doing a lot of different things. So I work with the American Academy of Neurology, work with the weightlifting team, the U.S. Olympic team. We're doing that again for France this year. I will be, I'm out and about helping different groups to understand the importance of their sleep, and also to change things like school start times, like daylight savings times. I work with the RLS Foundation. I'm on the board of directors there. So we're trying to advocate for people with this disorder that nobody really knows much about. There are a number of things that we have to lobby the government for, which puts me in a position of, trying to speak out on behalf of people with sleep issues. I work with the NIH, the National Institutes of Health, on the Sleep Disorder Research Advisory Board to help direct where we're headed with our research in this country. We need a lot more technology-enabled healthcare delivery. And within the sleep realm, that's where I'm working to try to get that done. That's what Absolute Rest is actually about too, is getting a sort of democratization of sleep healthcare and sleep-related science.
I love that. I'm excited to see how it all pans out the rest of this year.
We're excited too.
Yeah.
Thanks for having us on.
Yeah. Thank you for having me. Thank you for coming on.
Yeah, absolutely.